I could have my slides, please. So I think with dissection, it's a tricky subject, isn't it? There's a lot of different variables, a lot of moving parts in different areas. So I'm going to talk about false lumen endografts. So this is what we're dealing with. We're dealing with a dilated aorta over time with a thickened lamina with some calcification in. They become quite difficult to deal with, but we know that if they do start to enlarge, then we should think about doing something which is supported by the guidelines. But if you get it too late, then you're probably going to lose your landing zone. So it's probably trying to work out what the timing is to put these grafts in a safe manner. So we heard yesterday about the guidelines. There's multiple different guidelines. It can be quite confusing. Most of them agree that there is class 1 evidence with level B that if they do get to 5.5 centimeters, some say 6, that you should start treatment. It might be that you're actually getting too late in those cases. But if you could run all three of those videos, please. So this is a lady that came in. She was 72. She was treated. She came in with back pain, but no other adverse features. She was treated with best medical therapy, hypertensive control, statins, vascular modification. Could you run the other two videos, please? And you can see there's a bit of IMH there. It looks like IMH. There's some pseudoaneurysm formation in the vasa vasorum, but distally. Sorry, could you get those two other videos to run, please? If you could. Anyway, if those videos aren't running, they were running before. But you can see that there is a distal dissection in the best medical therapy and surveillance. So she's put on surveillance. This is our normal practice. She was sent home. We got her back for her 3-month scan, and on the 3-month scan, she started to get more back pain. She was actually readmitted around the 3-month mark, and she'd formally dissected by then and started to dilate up that segment of the aorta. We then decided that we'd put a TVAR in. We put a Gore C-tag device distal to the left subclavian, covering what was thought to be the entry tear on the initial scan, and she actually remodeled completely. So that final scan there was 2 years after the TVAR, complete remodeling. So you can get complete remodeling in that time frame. I think we caught it quite well. So if you just look at the last one probably now, just for time, you'll see that there's complete remodeling, and that even the distal visceral segment where it was extending into, all 4 vessels came off the true lumen. So moving on for time. There is evidence. So the IRAD database was one of the first to look at all this. Looking at best medical therapy alone, they showed that there was an increase in late complication rates and rupture. We had the INSTEAD XL and ABSORB trial, looking at uncomplicated TVAR versus best medical therapy. And it showed, as we all know, in a small number of patients, that there was a late benefit for TVAR in those patients that was transferred out to 5 to 10 years. But in chronic dissection, there's only really case series and meta-analysis. But we do know that 27% of these patients are just on best medical therapy probably will have a problem later on. So the question always has been, can we justify TVAR in patients without complications to prevent a late complication? This is what we're always challenged with. If we look at treatment windows, we know that in the acute phase, this is well documented now, that you do get more mortality and 30-day adverse event rates compared to TVAR, but there is still quite a high all-cause mortality rate in the TVAR group in the subacute phase. We know that a lot of them don't last 5 years, or they may have events in that time frame. If we leave them and put TVARs in the chronic phase, they do have fairly decent outcomes, but there is still mortality and morbidity associated with that. But a persistent false lumen in type B can lead to aortic dilatation. So what are the three treatments? So we can do the candy plug technique, the cheese wire fenestration that we heard from Prof. Wyatt, and the stabilized technique, which is done in the subacute phase. So we've never done the laser septation, but we have done one of these septal cheese wire septotomies. They're not for the faint-hearted. They are actually very difficult. We thought it'd be fairly straightforward to do it using an intravascular ultrasound and getting into the true and false lumen. They're very, very challenging to do, high dose rates, quite sweaty, and you don't know whether you've done a good result at the end until you put the stent graft in. So they are quite hard to do, and we've only done one because of the trauma associated with it. Candy plug, this is really based on when you've already got a TVAR in situ and you want to try and close off the false lumen. It always seems a bit worrying to me to put a load more of these grafts in, these physician-modified candy plugs with an Amplatzer plug in the center of it, into those false lumens, but it may be your only option to treat these unless you put a fenestrated device in distally. But there is some work on the, some evidence to show that there is good results with that. The stabilized technique, this is standard EVAR plus a bare metal petticoat. This shows really real promise, I think. There's good results on this, putting a bare metal stent below the, which we quite often do in some of these cases, but then they balloon this with a non-compliant balloon in the stent graft and a compliant balloon in the stent graft and a non-compliant balloon inside the bare metal stent to crush and split and compress the false lumen. But what can we do in the chronic setting? Well, we can do the septotomy type thing, but we can also, this paper from Mike Dake's unit showed a type of stabilized or Knickerbocker type procedure where they put a stent graft in and then they size it to the luminal diameter of the best part of the aorta that they can measure, and then they use a compliant balloon, a tri-lobe Gore balloon, so it allows flow past the balloon, and do an extensive, quite aggressive balloon inflation to try and split that lamina. And but you do have to have a landing zone, obviously, to do this, and do it 5 centimeters above the celiac. So there is this paper now, 40 patients with fairly good results, 1 death. But of course, this isn't new because we do have the Knickerbocker technique that we all know about, but this was done in the subacute phase. So in summary, there is some limited data on dealing with chronic type B false lumen management, but as a pragmatic point of view, in all our the way we work, the one thing that we do have on the shelf is these balloons. So it might be that we use this type of method to split the lamina, and if Mike Dake's unit does progress, then I think that the data on that can show that we could all do that in our practice. But I'd just like to also point out the trials that are ongoing at the moment. We've got the EARNEST trial in the UK, the Sunday trial in Scandinavia, and the Improve AD trial in the USA. The EARNEST trial that we're involved in our unit is going to start in January 25 and should start recruiting in February. So it'll take about 5 years to get all that data together, but it could be quite interesting to see what that shows. Thank you.